Welcome to the Mental Health Playbook Answers to Your Questions webinar. My name is Mary Mulco. I am a member of the WPS Provider Outreach and Education team, and I will be your host today. Joining me is my friend and coworker, Karen Curtis. Karen is going to be helping me today by monitoring the chat and providing you with additional information and links in that chat. Here is the objective and agenda for today. Our objective really is to share resources and answer your questions about Part B Original Medicare Outpatient Mental Health Services that were covered in our Mental Health Playlist series. The information presented really focuses on those claims for services that are billed on a CMS 1500 claim form. This agenda should look very familiar. These are the topics identified in our webinar description when you registered. And during today's session, we'll give you answers to all the questions we received during this Mental Health Playbook series. I want to thank those of you that's pre-submitted questions for today's event. This really helps us as we're going over those previously asked questions, and we know which ones that we need to answer today because they're new questions. And finally, we'll close with answers to any of the questions that you place into the chat, time permitting. I do want to draw your attention to the legal disclaimers that we've added to slide 12 of this presentation. And this is there really as a reminder that we would love for you to share information or education we provide with others within your organization or anyone outside of the organization with a need to know. But the information we're presenting today is current, but it is subject to change. You can find rules, regulations, and rulings out on the CMS website. Remember that the basis for answers given today rely on facts given in the question itself. Current Medicare rules will always determine final coverage, so make certain that you're making sure that the information out on the website is that which you are looking at. Finally, we ask that you refrain from recording any portions of this webinar. So I've inserted this slide, slide 3, to really provide you with a list of those webinars that we held as part of this mental health series. Both Karen and I have been having webinars about twice a month that pertain to outpatient mental health services. Now, if you happen to miss any one of them, I'll soon share with you some resources that you can use to learn more. So we had getting started, we talked about assignment, provider qualifications. We actually did a walkthrough of our local coverage determination, our WPS policy for psychiatry and psychology services. And we also walked through the companion article, or that billing and coding article, as we like to call it. We talked about billing services on the same day and bundling of services, how you can unbundle services, or how you can learn which services are bundled with payment or for Medicare payment. We also touched upon two very hot topics, those that I always get questions about when I'm talking mental health with folks, and that's Incident 2 and telehealth. And we also, to end that session of webinars, provided you with some specialty-specific webinars based on data that we pulled on common rejections and denials for the various provider types. Told you how to avoid those rejections and denials in the future and provided you with just a lot of really great resources to help you avoid those types of rejections and denials in the future, or to fix them. I do want to point out that CMS has a Medicare Learning Network webpage. This webpage provides you with links to a lot of great information, including resources and training, which includes those really wonderful, I think, Medicare Learning Network Matters articles. It also includes links to news, or how you can sign up for CMS newsletters. Some of them are provider specific, and also some great information about issues and how to avoid common billing errors and really make certain that you're complying with CMS requirements. And there is also a link to the CERT Outreach and Education Task Force webpage as well. Now, here is one of my personal favorites, a Medicare Learning Network product that CMS has published. Its title, and I've included an embedded link to it here, is Medicare and Mental Health Coverage. This is really my personal favorite and my go-to. When I get a question or I want to double check something, here is where I go. I go to this publication, keeping in mind that CMS does update it occasionally. So if you're one of those folks that likes to make a paper copy and refer to it, make certain that you're looking at the latest and greatest. There is a table of contents in this booklet that includes a lot of sections, if you will. One section is covered and non-covered mental health services, what is covered, what is not covered. Then CMS talks about those eligible professionals. It includes the qualifications. A lot of times I get questions saying, what are the qualifications for a clinical social worker? Here's where I point. It also includes information on that incident to payment concept and telehealth, and includes links to many, many resources as well. So it's a great booklet. My go-to, like I said, it includes links to those internet-only manuals. We at WPS also offer some mental health resources. I have put together a lot of resources here in one page, kind of a one-stop shop, somewhere you can go to pick up that information that you may be looking for. Sorry about that. I hit the scroll on my mouse while I was talking here, or while I was reaching for it. So here on our website is the Outpatient Mental Health Resources webpage with a lot of great resources, many of which were referred to during this mental health playbook series that Karen and I offered. And finally, before we dive into those great questions that you all asked, I want to talk a little bit about the WPS YouTube channel. Specifically, we have a mental health playlist that includes, over 20 recordings of past webinars or other recordings that we've made. If you missed one of the webinars in our series, you can go out to this playlist and find information for the topic of your choice. If you're looking for a handout for any one of these events, you can send us an email. The email is included here on this slide. It is wps.gha.education@wpsic.com. Include the webinar name and the date, and we'll get that presentation material packet over to you. Before the questions and answers, I do have one last thing, and I do want to talk just a little bit about overpayments. We receive many overpayment notifications and refund requests from providers. We know that you want to repay Medicare in a timely manner. However, there can be delays if you use an incorrect or an outdated form. Missing information or sending checks without explanations are just a couple of other reasons that can cause a delay. So to avoid unnecessary holdups, consider using the SecureNet Access Portal refunds or overpayment claim adjustment features. This really allows fast and efficient processing of your overpayments and refunds to Medicare. There are times when you are not able to use the online portal features, and instead you may choose to send paper requests and checks. And if so, we recommend that you include the correct form that's available on our website. I'll have Karen place a link to an article on our website that will help you determine which action to take or which form to use. Now, moving on to those important questions and answers. I have asked Karen to help me out here. She will post questions to me and I will provide the answers. And we're going to start with those pre-submitted questions for today's event. Karen?
Thanks, Mary. The first question that we have received is what needs to be charted for the MTP?
Okay, MTP, we believe, is the mental health treatment plan. The treatment plan is going to really provide a roadmap, and it's going to include goals and objectives. It is expected that the record will reflect the need for those cares and services provided, those on that claim you're submitting to Medicare. Include the type, the amount, and frequency or duration of services to be furnished, and the enrollee's diagnosis. The record must reflect the expectation of improvement in the patient's disorder or condition, or maintenance of a level of functioning. And remember that you need to sign and date the record. We do include, WPS includes documentation requirements in our local coverage determination. It is psychiatry and psychology services, and it lists bulleted points of those items that you need to include in your medical record. I mentioned the target symptoms, goals of therapy, and methods of monitoring outcomes, and why you chose that therapy, why that is the appropriate treatment modality, either in lieu of or in addition to another form of psychiatric treatment. If the goals aren't met, address those goals. Why are you going to change them? What are you going to change them to? Make sure that the patient's medical record contains documentation that really fully supports the medical necessity for that psychiatry and those psychology services as Medicare covers it. It includes, but is not limited to, a relevant medical history, a physical exam, and results of pertinent diagnostic tests or procedures. Individual psychotherapy CPT codes are used when the focus of treatment involves individual psychotherapy, and the policy includes specific documentation requirements for psychotherapy. So take a look at that local coverage determination. You can find it there. Documentation must always be available. It may be requested prior to payment of a Medicare claim. And if the claim does not indicate that documentation is available, it will be denied. Next question, Karen.
Okay, the next question we have is where they can find future education about mental health billing.
Future education about mental health billing will be posted as there is a need or a plan to provide that education. And this is just one other reason why those surveys that we ask you to fill out are so important. If there's something specific you want us to cover, uh, put that in your survey feedback. Let us know what it is you'd like to hear about. So that addresses future education. Other education or past education you can find in those YouTube recordings in that mental health playlist that's available out on the WPS YouTube channel. Next question.
Thanks, Mary. The next question is psychotherapy in the patient's home treated the same as telehealth?
Another great question. A patient can be seen in their home by a mental health professional, and this is not telehealth if they're actually being seen in their home. It's not telehealth because they're located in the same place, they're together. However, telehealth can occur when the patient is in their home and that mental health professional is located elsewhere. The service that is provided would be the same, it's just not delivered in the same manner. Next.
Okay, next question is, I am still fairly new to mental health coding and billing. What are tips for doing my job well?
Take advantage of all of the education opportunities that are offered. We currently have 27 videos on our mental health playlist. I mentioned this earlier. You know, just covering all things mental health. Ask questions. Another thing you can do is attend your professional societies and associations meetings or get involved, learn from others, take part in some of um, your professional coding organization meetings and such. And remember that the education that's published by CMS on their website is the most current education and it will always prevail. That is what determines the Medicare coverage. So make certain that anything you are looking at or referring to, number one, is from CMS or WPS. And number two, make certain that it's current. Great question. Next.
Where can I find more information about coverage and LCD rules?
We covered the local coverage determination for psychology and psychiatry services in one of our previous webinars. It was held on February 5th of 2026. Karen is placing a link to that in our in the chat. And if you hold just for a moment, I'm going to show you. This is the WPS website that I'm showing right now. We have a code lookup tool on the homepage of our website where you can choose to search for LCDs and article lookups by entering a term or a code, title, definition here in this box and choosing search. And when doing that, bring back any matches, taking a little bit of time today. And then you'll be able to see, and you can use the scroll feature here, any WPS local coverage determinations or coding and billing guidelines that include whatever it is you entered here in the search box. In this case, I typed PSYCH. One thing to remember, though, if you're looking for an LCD, CMS does not allow us to place a code within the LCD itself. So you'll not find a match for policies by typing a code, but you will find the corresponding companion article. If you want to view any of these LCDs or the coding and billing articles, you can simply click on them. And what will happen is a new window is going to open because you're actually leaving the WPS website and you're going to the CMS website. A new window opens. We house our local coverage determinations and our billing and coding guidelines in their entirety out on the CMS website. It's part of their Medicare coverage database, and that will always include the latest and greatest and most current versions of those local coverage determinations. Another thing I want to talk about while I'm talking about policy here, and I'm opening a policy, so you'll see I'm leaving WPS. I've gone to the CMS website. That's why I need to accept this new licensure agreement. A lot of folks ask me questions about something in a policy, and the policy is not one that WPS wrote. When we're talking local coverage determinations as opposed to a national policy, local coverage determinations only apply to the contractor that wrote or authored that particular local coverage determination. And as you can see, I chose to click on a link that opened the Psychiatry and Psychology Services local coverage determination. But one thing I want to talk to you about and give you a little tip here is as you're viewing these out on CMS's website, go here and click on contractor information and make certain the MAC that it is written by is the one that you're asking questions about. So in other words, if you're asking about J5 or J8 coverage for psychiatry and psychology services, make certain it is WPS that you see here and not another contractor, because other contractors do have local coverage determinations for psychiatry and psychology services, but you need to make certain that you are following the rules, so to say, or that policy as it is written by WPS. Next.
Is 95 modifier needed for telehealth sessions? And if the client is at work having video sessions, do you use place of service code 10?
Okay, let's see here. Let's pull this apart. Our education at WPS is that you use modifier 95 only for telehealth services and only when the clinician is in the hospital and the patient is in their home. I know that a lot of providers continue to use 95 modifier for telehealth services, but this is the only time that WPS is requiring it when claims are submitted on the CMS 1500 claim form. And that's really what we're talking about today. The other half of that question, there are two place of service codes to choose from for mental health telehealth. You would report place of service 02 when the telehealth is provided in other than the patient's home, and place of service 10 10 is reported when telehealth is provided in the patient's home. Next question.
Okay, next question, Mary, is what about updates on telehealth information?
We still get a lot of questions about what's new with telehealth, and it's been pretty quiet for a while. As those of you that have been around for a while know, there have been some changes that occurred during the public health emergency and during COVID. Some of the changes stuck around for quite a while. Some of them went away. For mental health services, a lot of those changes are permanent, but my go-to for all things telehealth is the Health and Human Services telehealth webpage. And I'm going to have Karen put that into the chat, the link to telehealth.hhs.gov. Telehealth is an effective tool that really expands that access to behavioral health services and to support access to telebehavioral health care. Telehealth policies allow FQHCs and RHCs to permanently serve as a distant site. Medicare patients can permanently receive telehealth services for behavioral and mental health care in their home. So that is something that is not going away. For mental health services, behavioral health, telehealth services, there are no geographic restrictions, and that is not going away. It's a permanent basis. Behavioral and mental health telehealth, that's a mouthful there. Those services in Medicare can permanently be delivered using audio only communication platforms. Marriage and family therapists and mental health counselors can also permanently serve as Medicare distance site providers. And eventually, some telehealth changes or updates coming around are those in-person visit requirements that are within 6 months of an initial Medicare behavioral or mental health telehealth service and annually thereafter, but that is not required through December 31 of 2027. So we have a while till that changes, and I'm certain that we'll be placing more education about that out on the WPS website as it comes along, or as those updates come along, I should say. For those of you that submit claims or prepare and submit claims for mental health services, behavioral health services, and other types of medical services, make certain that you are aware that mental health and behavioral mental health telehealth services have different guidelines. Okay, they're less restrictive. So you need to be aware of that. Anything else, Karen?
Yeah, our next question is looking to get more information on incident to billing for supervisors overseeing temp licensed counselors.
Okay. We did provide a 60-minute webinar on incident to services back, I believe it was in March. So look for that out on the website. But let me begin by telling you that there are 7 provider types who can supervise and bill for an incident to service. They are listed in that PowerPoint presentation, in the presentation materials too. They are MD, DO, CP, which is clinical psychologist, CNS, clinical nurse specialist, PA, physician assistant, NP, which is a nurse practitioner, or a CNM, and that is a certified nurse midwife. Only those 7 provider types can submit a claim to Medicare and be paid for incident to services that are performed by someone else. The next question I always receive is who can perform the incident to service? And the answer to that is that anyone who is acting within their state scope of practice can perform an incident to service. And this would include some of those temporary licensed counselors, okay? We do recommend, though, that all who perform services enroll in Medicare. And the reason for this is if during that encounter or during that service, that mental health service or telehealth service, if that service or the care that's being performed by the performing provider or the rendering provider, if that deviates from the billing provider's plan of care, that means that that service is no longer meeting Medicare's incident to requirements. And that means that unless you are enrolled with Medicare, you can't bill it. So we do recommend considering enrolling eligible providers that are rendering the incident to services. If they're temporary licensed, if they're able to enroll them, because what happens when that service becomes no longer an incident to service? We want to make certain you get payment for the services that are being performed. If that performing provider is not enrolled, then the service couldn't be billed if it deviates from the billing provider or that supervising provider's plan of care. Next question, Karen.
Our next question is, why are LMSWs paid at 85% of the fee schedule?
Okay, legislation, laws passed back in the early 1990s, and those laws grant CSWs part standing and allow those clinical social workers to receive Medicare reimbursement at 75% of the physician fee schedule. It's based on a law. Now, let's expand on that a little bit and talk about MFTs, those marriage and family therapists, and also mental health counselors. They are going to receive 75% of the physician fee schedule. Again, that's based on laws. Other non-physician providers, and those that you're talking about here, LMSWs are not paid at 85% of the fee schedule. It's 75% of the fee schedule. But other non-physician providers, PAs, NPs, and so on, are reimbursed at 85% of the physician fee schedule. Only legislative actions can change an existing law or create a new one. Okay, that means there's a law. It could be said then that it takes an act of Congress to change these reimbursement rates. Now, if that occurs, the proposed rule and then the final rule would be steps in that process. Those are the changes that CMS makes based on law that are written in the proposed and final rule. But those are steps in the process. So back to the answer here, why are they paid at a 75% of the fee schedule? It's based on a law. Next question, please.
Okay, next question we have is, what is the most common cause of denial on medical review related to documentation?
Well, this one is one that comes around often because of other types or all kinds of medical review. But overall, this cause of denial is the most common. It is insufficient documentation. Insufficient documentation accounts for the vast majority of improperly paid claims. There can be a number of reasons that kind of fall into that category, and it's usually missing or incomplete documentation to support the service billed. For psychotherapy, the documentation, of course, as I mentioned earlier, must support the goals of therapy and the methods of monitoring the outcomes. Now, it's important to identify those target symptoms and why that particular modality was the chosen treatment modality. Documentation has to support the patient's ability to take part in and benefit from that psychotherapy. And documentation must be complete, it must be signed. There must be documentation in that medical record to support that the treatment is expected to improve the health status or the function of that patient. It is important to note too that psychotherapy services do not include the teaching or monitoring of activities of daily living, recreational therapy, or social interaction. So these again are just, touching upon something I talked about earlier in documentation that needs to be complete. Make certain that everything is there that you're being asked to provide. Sometimes some of the medical review contractors will provide you with a list of documentation to send. Um, when your claim is selected for targeted probe and review, you will receive a list of items that you need to include, or that letter that you receive is going to actually tell you what it is you need to submit to support the service that you build. Next question, Karen.
Thanks, Mary. Our next question is how do we find the effective date once we're notified that the provider application was approved?
Well, this is a great question, and it does pertain to outpatient mental health. And this one was specifically one we're switching now, folks. I should have mentioned it just a little bit earlier. We're switching from those questions we received, those pre-submitted questions for today's session, to some of those great questions that we received during and following those other webinars in this webinar series. So this is a follow-up question that we received after our first webinar, which was back on January 8th of this year, called Getting Started. And the question is, how do we find the effective date once notified the provider application was approved? And that effective date is actually in the notification letter that you receive when your provider enrollment application is approved.
Okay, our next question is the partial hospitalization program billed per diem on the hospital side, not the professional?
Payments to hospitals and community mental health centers, or CMHCs, are paid on a per diem basis, and they're paid under the Hospital Outpatient Prospective Payment System, or OPS, for partial hospitalization program services, or those PHP services. Payment to critical access hospitals for PHP services is made on a reasonable cost basis.
Yeah, our next question is LCSW wants to bill 90846 for oncology patient family counseling. Could you please explain the R status?
Okay, the R status that's being referred to here is actually a status code, which you can find on the or in the status code column on the relative value file. And the RVF file, or the relative value file, is available out on the CMS website. I've asked Karen to place a link to that in the chat. The relative value file is the basis of payment for thousands of Medicare services. Each code that appears on that file has a status code. There is a document that you can pull up and look at to explain each of those columns, what each of those indicators within those columns means. And then our status in the status code on the relative value file means that payment for this code is restricted. Medicare can consider reimbursement for this service, or the service with the R status code, to an enrolled clinical social worker when medically necessary and otherwise covered by Medicare. If you go back to those earlier webinars in this series, or here and there throughout, you may have heard me use the expression, the service has to be medically necessary and otherwise covered by Medicare. In one of those two earliest webinars, I talked a lot about what does that mean? What does it mean otherwise covered by Medicare? Well, in addition to meeting medical necessity, which according to the Social Security Act, no payment can be made for any item or service that's not medically necessary. No Medicare payment can be made, I should say, clarify that. What it means when I say otherwise covered Medicare is, for example, I'll give you some examples. It can't be a duplicate. It has to be billed by an enrolled eligible provider. The service has to be provided to an enrolled eligible beneficiary, and so on and so forth. So in addition to medical necessity, it has to meet the otherwise covered by Medicare rules and guidelines or requirements. Documentation would need to show the medical necessity for the family psychotherapy provided. And it also has to show, and the coding and billing guidelines and the policy state this, it has to show if family psychotherapy is being billed, it has to show that that psychotherapy was for the benefit of the patient, not for the benefit of the family, patient's family, to cope with that patient's illness. So R means it's restricted. We're going to look at that medical record documentation when we receive the claim, a claim for 90846, which is family psychotherapy. And we're going to look at that documentation to show it meets all Medicare's requirements. Is it medically necessary, otherwise covered by Medicare? And was that service really for the benefit of the patient, not the benefit of the patient's family? Next question.
Okay, Mary, this next question comes from the webinar Assignment, Provider Qualifications, and Payment that was held on January 22nd. And the question is, where does WPS publish their provider qualifications for mental health providers?
Great question, and one we receive often. WPS follows CMS's guidance when determining provider qualifications. In other words, we follow those qualifications that they've published. You can actually find that in that MLN booklet that I talked about earlier. It's called Medicare and Mental Health Coverage. Let me take a quick look at that. Let's see here. We're going to go here. We're going to go to the CMS site. I'm going to look up that MLN article, which I happen to know is 1986542. This is just a simple way of looking for a Medicare Learning Network article, searching for it. Of course, there's a link embedded in the presentation materials for this. During registration for this series of webinars, we told you we're going to be looking at this booklet. You might want to have it handy. So I talked about this booklet earlier, and I mentioned to you that they have the table of contents. What I love about this is it's so easy to move around it. So here's your table of contents, provider information, and you can see the various provider types here. You can see incident to telehealth and so on and so forth. Let's say that I am looking for provider qualifications for clinical social workers. I can come to the table of contents and just simply click on it, and it will take me right to that information. And right here, the first in the items listed are required qualifications. These are not WPS's qualifications. These are CMS's qualifications, and we follow CMS guidance when determining the provider qualifications. All of these required qualifications are vetted during that enrollment process. So our enrollment staff is going to be making certain if this clinical social worker submits an application to us, before we can enroll that clinical social worker, among other things, we're going to make certain that all of these required qualifications have been met. So we'll be asking for copies of things like your license and so on and so forth. So it is the CMS guidance that we follow. There are internet-only manual resources on the last page of this document here. You can see the benefit policy manual and the claims processing manual. You'll find these required qualifications within the benefit policy manual, so you can click on this link. We referred to these qualifications and we walked through each one, just kind of calling out or making you aware that where you can find those qualifications during that webinar we held on January 22nd, and that is available on our YouTube channel. Okay. Again, each MAC is going to vet the credentials of every single applicant prior to finalizing their admission into the program. So for detailed information, though, related to enrollment, I would recommend that you contact customer service and ask to speak to an enrollment specialist. Next question.
Mary, this next group of questions is going to come from the webinar that was held where we covered the LCD and the companion billing and coding article. The first question is, during crisis intervention in the home, can a family psychotherapy occur?
The answer is yes. We can consider CPT 90846, which is family psychotherapy, when billed in place of service 12, which is the patient's home. The service, of course, must be medically necessary. It should directly address the treatment plan for the beneficiary and be otherwise covered by Medicare. And because it's family psychotherapy, of course, we're going to want to make certain that the service was for the benefit of the patient, not for the benefit of the family, to cope with the patient's illness. Remember, when rendering services in the patient's home, you're going to need to report the address where the service was provided in the appropriate item on the CMS 15 claim form. We can also grab that from the patient's address. Um, make certain that all of the information is on the claim form that needs to be included, those required elements of the claim, or required items, I should say. We have a, what do I want to say, crosswalk available that tells you if it goes here on a paper claim, then this is where you need to put it on the electronic claim. I do want to show you that. Okay, getting ahead of myself here. I'll go back here. I want to go back to the WPS website. I'm talking about the crosswalk, you know. Where do you put it on the claim form? We're talking about place of service here and reporting addresses for where services were provided. This is just something that I like to point out in a lot of my webinars when I'm talking about filling out that claim form, making certain everything that's required is there. If you go to the WPS website, and this is our homepage, I like to look under quick links to find EDI, Electronic Data Interchange. When I click on this, I'm leaving the WPS Medicare website and I am going to the WPS EDI website. You'll need to scroll down and choose between our WPS lines of business. We have Medicare, TRICARE, and then our commercial insurance. Choose Medicare EDI. Scroll down a little bit more, and under Medicare resources, you'll find the crosswalk. This is crosswalks the CMS 1500 claim form to the current electronic version claim. And what I'm talking about in terms of whether items are required or not required, or what we call situational, you can determine this by looking in the status code column right here. I'm trying to highlight it, but it won't work. Right here is the status code column. If there's an R here, that means item number 1 is on the paper claim form, or the electronic equivalent, which is here, is required. The information over in the far right column are those requirements for the version 5010, the electronic claim form. So I like to point this out to people when I'm talking about rejections and denials and making certain you're reporting things correctly. For example, the patient's address on the claim. If there's an R here, it's required. If it's an S, it means that it's a data element that must be completed, but only if other conditions exist. If you fail to place one of these items with an R on that claim, your claim is going to reject. It's an incomplete claim. Okay, so just an aside there, some other great information, but we're talking about place of service and making certain you know where to report that on the claim form. That and the physical address as well. Back here and then back to the PowerPoint. All right, Karen, next question.
Next, we have, do the targeted symptoms need to be an exacerbation in order to support the medical necessity of psychotherapy?
Remember the documentation requirements in the local coverage determination. That medical record should document the target symptoms, goals of therapy, and the methods of monitoring the outcomes. Why was this the chosen therapy? Why is this the appropriate treatment modality in lieu of or in addition to another form of psychiatric treatment? That's what you need to place into the documentation in order to support medical necessity for psychotherapy.
Okay,
Next.
our next question is, per the LCD policy, it states under psychotherapy that although maintenance per se is not covered, Helping a patient maintain his or her highest level of functioning, such as a patient with borderline personality disorder, may be covered on a case-by-case basis. These case-by-case considerations must be supported by the evaluation of a plan with a clearly identified goal. Can you please provide WPS's definition of maintenance and provide an example that supports and doesn't support ongoing maintenance?
Great question, one we receive often. There is no published definition for maintenance by CMS. Therefore, WPS has not published a definition for maintenance. We don't provide examples of what is and what is not maintenance because claims require review on that case-by-case basis. That's why we've used that language. Documentation for each patient is different. Your records must show that the psychotherapy is designed to sustain progress made, prevent relapse, and to manage symptoms. There needs to be reasonable expectation of improvement in the patient's disorder or condition. And this is going to be demonstrated by an improved level of functioning or maintenance of level of functioning, where decline would otherwise be expected in the case of a disabling mental illness or condition or chronic mental disorder. So when a patient reaches a point in his or her treatment where further improvement does not appear to be indicated and there is no reasonable expectation of improvement, then the psychological services would no longer be considered reasonable or medically necessary, but only that documentation is going to show this. It's a case-by-case basis. Next question.
Can interactive complexity be used when therapy is for a young child that may have difficulty expressing themselves due to age only?
Interactive complexity may be reported with psychiatric procedures when at least one of four communicative disorders is present. They are the need to manage maladaptive communication among participants that complicates the delivery of care. Some examples of that would be the related to high anxiety or high reactivity, repeated questions or disagreement. Another interactive communication or communicative disorder for which you can bill interactive complexity would be caregiver emotions or behavior that is going to interfere with implementing that treatment plan. Another is the evidence or disclosure of a sentinel event and mandated report to a third party. This could be abuse or neglect with report to state agency. And then, of course, this is going to be also with the initiation of discussion of that event or report with the patient and other visit participants. Another communicative disorder where we can consider reimbursing for that interactive complexity add-on code is the use of play equipment or physical devices, interpreter or translator to overcome significant language barriers. And when we talk about interpreter here, I always like to make certain people understand that's not translating from one language to another necessarily. It's when there is a need for someone to interpret the language barrier. One of the examples that one of my colleagues years ago used was if the patient, for example, speaks Klingon. Okay, there may be the need for an interpreter in that case. And remember that communicative difficulty must be included in the documentation whenever you are submitting a claim for interactive complexity. That's an add-on code to WPS.
Mary, our next question is coming from the webinar, Same-Day Billing Guidelines and Bundling. We were asked, how can I tell if a service will bundle?
Good question. There is a couple of different tools that we use to assist in correct unbundling or bundling of payment for mental health services that are submitted for services on the same day. And one of those tools is the one I talked about already, that CMS relative value file. Remember I talked about the status code column? We talked about what an R meant. If the status code column for an item or service on the relative value file is a B or a P, then that item or service is always bundled and the provider cannot receive separate payment for that item or service. B or P status code means nothing you can do, no modifier you can add is going to allow us to unbundle payment and make payment for both of the items or services that you're billing. You can't bill the beneficiary for these items or services, anything with a B or a P. Now, we also use the CMS procedure to procedure edits, and this is part of the CMS National Correct Coding Initiative. They are edits that are available out on the CMS website. They're edits used when processing the 1500 claim that we're talking about today. And Karen has placed a link to those edits out in the chat. Next question.
We have a couple of questions that apply to the Incident 2 webinar. The first one is, one very common question we continue to receive is whether the supervising provider that bills the Incident 2 service has to co-sign when performing the provider, or co-sign the performing provider's note. Sorry, do you have any information on that, Mary?
I sure do. We know that some MACs have published that this is required. However, we can find no CMS published directive that states that the co-signature of the supervising provider is required on the performing provider's medical record entry. I confirmed our stance in our education. I've been teaching or educating about Medicare mental health, outpatient mental health services for a long time. I confirmed that what I've been educating for a long time remains our stance. I confirmed this with our WPS contractor medical directors. Our education has been and remains that WPS does not require a co-signature on the performing provider's entry. I'm talking about the signature of that individual who is supervising and submitting the claim for that Incident 2 service, not the person who is performing it, okay? Our education is that we don't require that co-signature. However, there's that big however, folks. There must be evidence in the medical record documentation to support that all Incident 2 criteria was met. And we all know that whenever there's documentation in the medical record, WPS and CMS requires that it be signed, okay? I contacted CMS and suggested to them that they include an answer to this very common question in their published education. I told them, we know that some MACs require the co-signature. We do not. They did not respond that a signature by the billing provider is required. They did not say, what I'm talking about is the co-signature on the note. They did not say that the education we provide is wrong. They did say that they will not be making a change to their published Incident 2 education. In other words, they have no plans to make an update that says specifically that they require the supervising physician's co-signature on the performing provider's medical record entry. We will continue to require evidence in the medical record that the supervision occurred and that the billing provider remains actively involved in the management of the patient's diagnosis. Now think about this for a minute. If there is an audit and someone comes in and sees a co-signature of a supervising physician on the performing physician's note, does that mean that the provider remains active involved in the patient's or the management of the patient's diagnosis? No, it just means they co-signed the note. What we would look for is that signed documentation in the patient's medical record to show that the Incident 2 criteria is met. How are you going to provide evidence to us that shows us that that billing provider supervised the Incident 2 service and that he or she remains actively involved in the management of the patient's diagnosis? That is up to you how you will include that documentation. But I would caution you that a co-signature alone does not necessarily provide that evidence. So find a way within your organization to, if you're, billing incident to services, to document that, yes, this provider is remaining actively involved in the care of that patient's diagnosis. I met with someone that represents a psychiatric practice the other day, and that individual told me that their billing providers actually meet with those providers that are performing the incident to services and discuss the patients. Document that. That shows, you know, that they remain actively involved in the patient's diagnosis or the management of the patient's diagnosis. Also, document the supervision in some way or form that you choose and submit those records if asked for them. Another thing to remember with incident 2 is that one of the criteria for payment is that the service has to be incidental. You need to remember that you need to send that plan of care along with the patient. And I just got really long into that answer, and that's the end of the prepared questions that we had for you today. I recognize that there's likely some that came into the chat. If there are a lot of them, what I can propose to do is to consider adding another webinar, or I can simply write answers to all of the questions received and send them out to all of you following this webinar. I'll also be talking in just a moment about ways you can submit questions for a period of 7 days following this event. But we have come to 11:01. I apologize for going over. I was talking so much about that question that we keep getting asked that I didn't look at the clock. But I do want to finish up here or close and talk to you a little bit about that survey. We ask you to complete following our live events. When you disconnect from the webinar, you will be redirected to a CMS survey. If you've not already taken the survey, we're asking for you to complete it at that time. You can do so now also by using the link that Karen has placed into the chat. I really hope that you'll take a moment to provide feedback on how I did today. If you're watching this video as an encore, you're going to see a pop-up at the end of a webinar with a picture that says survey. When you're leaving the webinar today, you're going to see, I mentioned that redirect. It's going to show what pops up or what is shown here on this slide. It says external site. It's not malicious or anything. Feel free to click on it and complete that survey. As I mentioned a couple of minutes ago, we just wanted to inform you or let you know that you're going to see that pop up. Looks like this piece here on the right side of your screen. There's a yellow triangle at the top and a blue button on the bottom. The feedback we receive really does lead to changes. We actually publish the changes out on our website. We've made changes to our education activities. Your opinion really does matter, and it makes a difference. And we take action depending on what you put in those surveys. After disconnecting today, you should receive a thank you for attending email, and that email will come from WebEx. It will contain contact hours that can be submitted to the accrediting body of your choice to request continuing education units. If you joined only by phone, WebEx is not going to generate that email, so you will need to send WPS an email. Karen has placed the education mailbox address into the chat so you can send us that request for a certification that shows, or a certificate that shows that you attended our event today. It's not an attachment, folks. It's in the body of the email. If you think of any questions, those can be emailed to us for a period of up to 7 days following today's event. And you can send that to our education mailbox. Please place the name of this webinar and the date in the subject line, and the staff that's monitoring our education mailbox will send that over to me quickly. I will prepare answers to all of those questions. I will consider adding another webinar to our schedule so we can take more of your great questions. They really are great, and again, I appreciate all of those pre-submitted questions. This does bring us to the end of today's presentation. On behalf of myself and Karen and all of our provider outreach and education team, I want to thank you for being here today, and I hope you will join us for future events. You may now disconnect. Thanks, everyone.